on the chat before we start, Diana. There's a comment here that says that someone missed last week's presentation and they can't find the recording. You help them, Diana or Joel?
Yes, it should be on the website, but we'll follow up on that. Thank you for noting.
Okay, so we might put the link in the chat. Is that okay? Or something like that?
Yeah, that's okay. Oh, okay, then. Yeah.
And also remind you of the website for the mental health data prize, which should contain all of the recordings there so that you can access them then.
Okay.
Second question, Diana. Later on, I was going to have a bit of interaction and get people to respond to some of the questions. Can people unmute, or is that not allowed at the moment?
At the moment, they cannot unmute unless maybe you enable them. So maybe if anyone has a question, we can be able to unmute them, then they can ask the questions. So they'll raise their hand.
So they can raise their hands and then I can unmute them and then they can make a couple of responses. Yes, okay, because I think interactive and participatory rather than just listening, because I think that's good. Okay, good. Okay, right, thank you. So I must admit that I too missed last week's presentation, so I didn't know exactly what's going to go on here. And my task today is to talk about epidemiological methods for mental health research as part of the training for the Mental Health Data Prize in Africa. Now, epidemiological methods for mental health research are very epidemiological methods for other kinds of research. So some of these things are specific to mental health, but most of them are pretty general. So just look at, hopefully everybody can hear me, is that right? If you can't hear me, please put a note in the chat to say that you can't hear me. I noticed there's a couple of people there who said they couldn't hear earlier. Hopefully you can hear now. Who is that? Gloria. Gloria said she couldn't hear Diana talking, and Abraham also said that. So if you can hear now, please let us know. Okay, thank you, Ronald. Thank you, others. Yes, Emily, Emil. Yeah, good. Okay, right. So let's get started then. So what are we going to do in this presentation? Let me see if I can move my slides on. Yeah. Okay. So the objectives and the introduction to this course here is that epidemiology is the study of the distribution and determinants of health-related events in populations. So as opposed to clinicians who are very much focused on the individual well-being of their patients, then epidemiology is much more about studying the whole population and the distribution of those diseases and those events which we see in the population. And moving on from just describing the distribution and looking at the frequency of different events, we're also interested in evaluating the impact of the interventions on health in the population. That doesn't necessarily mean to say that everyone is going to get better, but the interventions may improve the health of those in the population overall. This course is going to be very, very, very basic. It's going to start off with epidemiology 101, as you might say. It's going to start with the very basics of measuring mental health conditions, of study design, and evaluating effects or impact. That's because I'm not quite sure where everybody is here, and I think there's more than 200 people on this webinar. So therefore, I'm not going to be able to cater for everybody, but I do think that it's possible to start off with the very basics, and people can see where we go from that in later sessions on this. So those three basic methods, the measurement of mental health conditions is going to be the first bit. The study design, different study designs that we can use to do some of our mental health research, and then to evaluate the effects of the interventions are going to be the basis of what we're going to talk about these. So each of these three sessions, I will give a short introduction. I'll then give you a question or a task for you to tackle. And, I'll give you 10 minutes or so to discuss and, see what you have there. And we can start to get some answers and see what other people think about that. In that way, hopefully, it will be a little bit more interactive and proactive, and it make it more interesting for everybody as well. Yeah. Okay, so where are we at? So measurement of health events. And I think that the basic measurement of health events is the frequency and prevalence of disease. And, when I say disease, I'm also talking about mental conditions here, conditions such as depression, anxiety, psychosis, trauma, and other things like that. So see me say disease there, I'm also talking about mental health conditions as well. So the first idea is we're going to, the frequency, we're also going to show how we can measure the prevalence of these diseases, and then we're going to move on to have a look at the incidence of disease or conditions, showing us how we can measure those as well. I think an important part of this is to say that every measurement or estimation that we have, we need to define a standard error, which is going to show the variability or the variation that could happen in that measurement within the population. And then we'll see how we use those standard errors in our research. And then the final slide or two is going to be on sampling from a population. How do we sample from a population? We can't necessarily measure everybody in the population, so we need to think about sampling in some ways. Okay. Epidemiological methods. So epidemiology is concerned with the events or the diseases that occur in populations. Really, the individuals with the disease are going to be the numerator. How many cases do we have with particular conditions? And, the first thing we can do is describe the characteristics of those with the disease. So if we have a population that we represent here with the, in the orange disc here, then we'll have a population with some people with the disease and some people without disease. And we might say, well, what we want to do is to describe the conditions of the disease, and then we can describe the severity of those conditions, the causes and the consequences. We can look further. Once we've described the demographic characteristics and the clinical characteristics of those with the disease, we can go further into looking at the severity, the immunology, and many other things there. And we can look at risk factors and causes for those who have the disease and compare them to those who don't have the disease, so that we can get some idea of what might be the cause of the infection or the disease. We might then want to look at the consequences, what happens to people who, and so we follow up those ones with the disease over time, and we can see what happens to them, whether they get better, whether they get worse, whether they infect other people, and whether they die of that particular condition, or any other consequences that we might have. The first thing I'll say here is that when we do these kind of epidemiological methods, we want to define our cases very clearly, so that we know who we're talking about and what we're talking about. If we just say we're going to be looking at mental health, that's not a very specific condition. What we want to do is to say, what are the definitions of that mental health condition that we want to study? Is it focused on one particular condition, such as depression, or is it focused upon people who come to hospital with a series of different conditions that might affect their mental health? The next part of that is for any analysis, and going on from description to the analysis, then the population at risk will need to be described here. That is what I would call the denominator, the people who are at risk of this disease. We want to know how many people are at risk and to give the prevalence or the proportion of people who are with these conditions. But we might also want to know how long have people living with this at risk with the disease before they actually get the disease. And that will give rise to what I call the incidence of disease here. Just going to stop here and say to Joel, I see people would like to get to share the PowerPoint presentation I have here. Can you share that with everybody here? There's a couple of people who put their comments there. So can you share that, Joel, with everybody in the all the participants?
Yes, we will put all the content on the platform as well as on our YouTube channel. I've shared the two links, so kindly use the links to access all the materials. We will be uploading them after the call.
Okay, let's have a look. There's a couple of people with raised hands. Let me see if I can find who they are. And then I can ask them what they might say. So Kyoko, let me allow you to talk. Can you reach it? And Elizabeth as well. Do you have a comment on what I've said so far?
Sorry, it was a mistake.
Okay, sorry, no problem, no problem. Kyoko Ndunda. Clifford, got your hand up as well, Clifford. No problem. Okay, you can unmute yourself if you want to talk. I'm going to mute Elizabeth in case any untoward noises come up from there. Right. Okay, let's carry on. Where are we up to here? Yeah, good. Yeah, okay, good. Yes, so where are we up to here? So let's define our cases. What are we actually looking at here? Who are we thinking about here? Well, the first thing to say is that if we're going to be doing some epidemiological research onto mental health, we need to actually standardize the definitions of who are our cases, what are the cases that we're going to be looking at, and these are key to successful research here. This definition of mental health conditions might be for depression, it might be for anxiety, it might be for psychosis, it might be for trauma, it might be for anything like that. But the definitions that you use for your research may differ from the clinical case definitions. You don't have to go to the case definitions in the clinical guidebooks and say, this is what I'm going to be using. You may actually be screening for conditions in populations, and you may have a set of screening questions that you want to use in that population. And so if you do that, make sure it's very clear what is your case definition, what is the standardized definition that you're going to be used to define cases in your particular research. Then you might want to say, well, how are you going to use this to identify cases? And again, you might have active methods. You might be saying, well, we're going to go out into the population and we're going to ask everybody in the population these questions. So you might have some active methods to screen people for depression or anxiety or whatever it is you might have, in which case that would be you'd need to define how you're going to do that. And we'll get on to the sort of like sample selection that you might have for your particular research study. You might then say, well, we're not going to have active methods. We're going to stay in the health center. We're going to stay in the hospital, and we're going to see people who are going to come into the health services for treatment. And then we're going to have that passive method for detection of cases. Now, both are very useful and objective ways of doing it, but you need to describe and say which one you're going to be using before you can do your epidemiological research. The number of cases that we get usually form the numerator in this. In other words, the number of cases is the number on top of our ratio or prevalence that we're going to get, and we'll then be able to measure that disease frequency in our population. Another point that I just want to make here is that in any study, we may have several outcomes. We might be defining cases of depression, we might be defining cases of anxiety, and we might be using several different cases there for that. I think I have here, yes, an example here is to, we might be using the GAD-7 tool to measure anxiety. I'm not sure whether everyone is aware of the GAD-7 tool, but that's a particular set of 7 questions which have been developed and which are validated to measure anxiety. And so people with a cutoff greater than a particular cutoff will be considered to have a measure of anxiety, and people who don't have that measure will be said to be free of anxiety. So we might be using the GAD-7 tool as one of the things, one of the measures that we're having in our study. But then we might also have another study, the same population. We might be using the PHQ-9, which is a different set of 9 questions which are used to measure depression in a population. And so we might have both of these different population measures which we're screening for in the same population. Alternatively, we might have a more clinical looking at people in the health of the hospital. We might have a clinical tool which will measure psychological events within the population. So all of these are valid definitions of cases, and what you need to do is decide which one you want to use in your study. And then we come along to the very matter of what are we actually going to measure. We need to define the number who are at risk. And as I said here, this is usually the denominator here. And that's the population from which the case originated. So if we're saying we've got some cases attending our health center or our hospital, then we'll say the population that is served by that health center or clinic is going to be the population at risk of this particular condition. And they would then be in the calculation if they fulfill the criteria for your definition of your case. Now, a study that defined geographically, we might say the whole of the UK, the whole of one region of a country, or we might then further define our population as being, we're just looking at adults. And in that case, we'll define adults as people aged 18 years or more. And if they're aged 18, they'll be part of our population. If they're not, then they won't be included in our population. We might be looking at women, especially if we're looking at maternal conditions, because men don't have maternal conditions. So we might look at women and see about the mental health conditions that they might have look at the particular prevalence of mental health conditions within a particular set of women who are pregnant or have recently delivered. We might look at particular races or particular ethnic groups, or we might look at other characteristics and define that as the population that we're interested in. And of course, this can be a little bit more complicated than it would be first appeared, because although we might define the denominator as people who come to the hospital from a particular population that they serve, there may be people who come to that hospital who don't belong to that population, who are visitors who come from further away and who don't appear in the population serviced population of that hospital. And the question then is, do we include them or do we exclude them from our research? Of course, if we're looking at disease frequency, we might just be wanting to describe our cases that come to the population, in which case that's okay to include everybody that we have there. But if we want to get an accurate picture of the frequency and the prevalence of a disease, then we need to know who our numerator has and who our denominator has in the population. Okay, so this is a little diagram that I've put up here to show how we might measure our disease frequency. And we can think of a population here at time 0. and we have a full population there. And then as time goes on, some people get the disease and some people don't get the disease. And that's sort of shown by this sort of like line that comes down there. As we have people who get the disease at any time point, we will say, yes, they have the disease, and we can tick them off and say, yes, criteria for the definition of our disease there. And so after a period of time, after time t, we would have the population would have a number of people there who are cases, and we could say that we would have those number of cases, that is D, the number of cases in our population, and then we'd have the number of people who don't have the disease at that time point, which we can say is the population n minus those with the disease. So it's going to be n minus d. So at a time point t, we might then have d people who are cases with the disease, and people and n minus d people who are not cases, who are don't have the condition or the event that we're looking at. So if we're going to measure at a particular time point, the proportion of persons in a population who are cases of the disease at a time at a point in time is going to be that the prevalence is the number of cases, which is D, divided by the total number in the population. The prevalence doesn't have any units, it's just a number, it's just a proportion. But we should, when we mention what the prevalence is, we should state the time that it is. This is in August 2022, the prevalence of depression was whatever it was in our population. And of course, the prevalence at any time point will depend upon the number of new cases that are in our population. But if you can see from the stepped line that comes down from the time 0 to time t, the duration is also important, in that some people might get the disease early on in that time point, but then they might recover and become better. The measurement of our prevalence at time t, in which case they won't appear in our prevalence estimate of the disease in the population. We need to define our time period. We need to say, well, the disease frequency relates to a particular time point. As I said, it might be August 2022 when we did the survey, and that will be the measure that we have at that time point. And if we did the same measurement a bit later or a bit earlier, we would get a different number who had that disease. And the most important descriptive measure here is the prevalence or proportion of people who are positive for the condition at that particular point in time. But of course, there are other measures that might be used, such as the odds of disease. And the proportion is the one that is often quoted for the descriptive measure, but the odds are often used for analytic measures. So the odds are given not by the in a slightly different way from the proportion, in that the odds are that the number positive, not divided by the total number in the population, but the number positive D divided by the number negative, which is n minus D. And so we have the odds, and the odds are not the same as the proportion, except when the disease is a very rare disease. The other important thing to say about the measurement of our condition is that we can't measure the whole population. If it's a very small population, we may be able to do, but most of the time we can't measure the whole population. So we'll take a sample. And if we take a sample, then we will need to make some statistical about that sample in order to relate that sample to the whole population. And I'll say a little bit more about this later. Okay. Any questions so far? The question here from Belachu in Ethiopia, is the prevalence the same as the probability? I would say not. I would say the prevalence is the same as the proportion. It depends what you mean by probability. If you mean what is the probability of one person in the population having that condition, then it would be the same. But that's not a common idea of probability. The probability is more about chance and about the probability of something happening in the future. So I would say the probability is probably not the good word to use. I would use prevalence or proportion. Prevalence being 100%, the proportion multiplied by 100. Okay, there's another question here. What is the difference between prevalence and lifetime prevalence? Lifetime prevalence just means the cumulative prevalence over time, over the whole of one's lifetime, as to whether or not you might have a particular mental health condition. That's because some people might have depression for a period of time, and people might get that depression for a period of, sometimes it's weeks, sometimes it's months, sometimes it's years. Sometimes people might have depression for a period of 2 years or 3 years. Now, what they're saying is lifetime prevalence is just the cumulative prevalence over the whole of someone's lifetime. And there are, the lifetime prevalence. It might also be called lifetime incidence, cumulative incidence. There's many different words that are used there, but prevalence, strictly speaking, refers to the proportion of people, the prevalence of people who have that condition at one particular point in time. Lifetime prevalence, whole of the lifetime, and just say the whole of that period, but it's, strictly speaking, prevalence is referring to a particular time. Okay, let's go on to the next one. Now, this is a slight diversion from what I've said before, in that when we have some measures, the frequency is often used to describe the proportion of people who have that condition in the population. But to be really useful, and to be especially useful in the analysis of our data, we need to have something called a standard error. And every estimate or measure that we have really needs a standard error. And a standard error is a statistical term which shows the variability of that estimate. What would happen if we took another sample? If we took another sample from the same population, we'd get exactly the same result. We'd get a result which was slightly different. What is the variability of that estimate across these different samples? And the standard error does depend upon the type of measure that we have and the sample size of the denominator, how many people we've chosen in our sample. The standard errors can be a little bit complicated and a little bit confusing to some people, but basically it is a measure of the variability of the estimate. And it's an important statistical tool in which we are able to then use that for a couple of things. As I said at the bottom there, standard errors are used for two statistical. One is to test the hypothesis about the estimate, and usually we define a null hypothesis for the estimate and say the null hypothesis is that the prevalence is going to be 10%. Let's look and see whether the prevalence in our sample, in our population, is the same as we would we hypothesize about that particular sample. The second way that our standard errors are used is by creating a 95% confidence interval, just written as 95% CI sometimes, which shows the range of values that we would get from similar samples taken from the population. We'd say that we're 95% sure that the samples in this population would have a prevalence somewhere in this particular range. As I said, standard errors are dependent upon the type of estimate that we're making. And if we're looking at proportions, where we're looking at the proportion, the number positive over the total number in our sample, then the standard error is defined as the square root of the proportion multiplied by 1 minus the proportion, in other words, the number who don't have the disease, divided by n. And so that is the definition of the standard error for proportion. I'm not going to go into a lot of detail about standard errors. You could have a whole lecture on standard errors if you wanted, but I'm just saying that if we do a study and we estimate a particular measure, whether that's the proportion, the odds, or we should be able to get a standard error for that. And the standard errors that we can get for these different measures are all contained in the textbooks, so you can look them up. Okay, the other thing that we might want to be measuring is the disease incidence. And here, disease incidence is different from disease prevalence, because the disease incidence, the incidence of depression, is more like what was mentioned there by Mustafa, is the number of people who are new cases of that disease. And we define that over a period of time. So the incidence will be the new cases, the number of cases that get that disease over the time at risk. And here we have to measure the time between the beginning of the measurement to the end of the measurement so that we can get the proper estimate of the total time. So here, if someone gets a disease early on in the time period, but then gets better, they would still be counted as an incident case of the disease during that time point. So the incidence here is going to be the number of cases in the population divided by the total time at risk. And incidence does have a unit. It has a unit as the unit of time that we're using there. If we're using days, then it'd be per. If it were using years, it would be per year. And many times for rare diseases, we will be saying over per 100 person years, how many people will get this disease over per 100 person years. The tricky thing about incidence is that we need to add up the time at risk for each person. Because each person will have an entry date when they come into the study, and they'll have an exit date when they exit the study. But that exit date and that entry date may differ from one person. And so we need to be able to take into account the different entry dates and exit dates that we might have. The other thing is that some people might exit the population without experiencing the disease, in which case we'd call that censoring. Okay. I see that there's a question here from Anna Reen, which says standard error versus standard deviation. What are they different, and what to report when? So this is a very common question in statistics classes, and I wasn't going to go into this in too much detail, but just to say, yes, standard errors and standard deviations are different. Standard deviations are related to the variance of the mean. It's about estimating the variability of a mean, and it's related just to that particular kind of measurement that you might have when you're measuring continuous data over a period of time. And the standard deviation is the square root of the variance of that those particular observations. So standard deviations are related to normally distributed data, and that is all they are related to. Standard errors are something which are related to every single estimate that you have, whether it's from a normal distribution, whether it's from a binomial distribution, whether it's from a Poisson distribution or a negative binomial or a gamma distribution, whatever distribution we have, we should always be able to get a standard error to describe the variability of that particular estimate that we have. So standard errors and standard deviations are very different, and we should make sure that we're looking at the right thing when we're looking at the standard. Should be estimated, it should be obtained for every estimate that we get. And most statistical packages will give you standard errors output. Okay, so measuring incidence, getting back to the topic here. Measures of disease frequency which happen over a particular time period are usually called incidence measures. And it's important to specify the time period that is being used there, whether that is a few weeks, a few days, a few years, or maybe longer. or even, as Mustafa says, over the whole lifetime, the cumulative incidence can be calculated over that. So the incidence of an outcome then refers to the number of cases that occur within a period of time. It's not about a specific point in time, but it's about over a period of time, and therefore is reported per unit of days, years, or months. Incidence counts the number of cases that occur within that given period of time, even if those cases get better or die or do something else before the end of the study. The incidence is a rate, and it does have the units of time as a denominator. Just to say, and I think here is where I mentioned about sampling, the whole point is that we can't look at everybody in the population. If we wanted to look at all pregnant women in a particular country, that would be impossible because we wouldn't really know about every single case within every single person within that population who was pregnant. So we might want to know something about the prevalence of mental health conditions during pregnancy, but we can't measure that disease in the whole population. And so that is the question about how to measure the prevalence of disease in the whole population. Well, the answer then is to take a sample, and the most important represent a sample that's going to represent pregnant women in the population, or represent university graduates within this population, or represent some other type of people within that population. And so taking a representative sample is a whole area of expertise in itself. And again, you can have a whole lecture on that. I'm not really going to go into that, just to say that epidemiological research is about taking a sample from the population and then measuring our outcome within that sample. The important thing about the representative sample is that if it's properly constructed, we can then use that sample to say something about the population. And that's really statistical inference. We use that sample to say something about the population. We measure the disease in the sample and say that because it represents the population, that will be a useful measure of the prevalence of disease or the incidence of disease within the population. Okay, there's a question here somewhere. Yeah, someone's got their hand up. Who's that? No, I can't see it. Okay, yes. Saina Boy, do you want to ask your question? I think you can unmute.
Thank you, Tom. This is a really essential part of this training, and
all right.
Yes, I'm kind of a newbie in mental health research, even though I've been in the field of research for quite a while now. So I was just wondering, because there is this pre-award project that I am trying to put together. So I was just wondering, is it, because we were trying to do like a situational analysis of the mental health conditions or issues in the Gambia, not conditions, but issues in the Gambia. The Gambia is in West Africa. You know, it's where MRCG is situated. Yeah. So my question actually is, in terms of the sampling, if we are trying to do also a prevalence component of that project, do we have to still do like a sampling calculation, or should we look at every single region within the Gambia and do a sampling population from it?
Okay, so that's a sort of question about sampling, which I wasn't really going to cover too much in, but of course, it's quite difficult to cover every single region in a country, even if the country is quite small like the Gambia. And you may select a number of regions to do that. And then you would select, this is called a cluster sample, in which case you would select your clusters to begin with, and then you would select a number of people within each cluster to take your measurements from. And your measurements might be on, might be on the prevalence of, it might be on a particular condition, let's say depression or anxiety, but it might also be about awareness of mental health conditions amongst health workers. You would be sampling from your health workers there. So there would be an element there that you would be sampling a certain number of regions from the in the country, or districts, or villages, or wards, or health facilities, or whatever it is that you're looking at there. And then you might then sample 10 or 20 different people from each of those, or 100, or many. It depends on your sample size, how many people you want to choose from each of those clusters that you've chosen within the country. So cluster sampling is a very common way of collecting samples from your population. Yes. Okay.
Thank you for that answer. And I also was just wondering one more thing. Are you open to someone reaching out for you in terms of support in fine-tuning their research idea?
Sure. I think the whole team here, I think within APHD, there's a sort of team of about 5 or 6 of us, as well as a number of people who are giving the lectures. And I think all of those, Sylvia, Joel, Muluse, and others are all there to support. Will give us some more information about that as we go along. Okay, a couple of other people here who've got a question. Is that Amos, is it? Amos. Cool.
Hello, thank you so much, team. It's so pleasure having you here, and the presentation is so good. Actually, I was raising my hand to respond to the person who was asking a question about sampling, but you have handled it.
Okay.
So I have some
Amos, give us
there.
your thoughts as well on sampling, because it's always good to get thoughts from the participants as well.
Yeah, sure. Thank you so much. So I wanted to add on to what you said, that the sampling method that you select is mainly determined by the target population that you wanted to research on. So in some cases, maybe you want to do a research on a very rare condition or a very rare disease. In that case, you have to use a certain type of sampling that maybe does not require maybe randomization or something like that. So maybe to just give a wider categorization or grouping of sampling methods, we have the probabilistic ones and the non-probabilistic. The probabilistic ones are the ones that you are trying to have every member of the population have equal chances of being sampled into your sample. And the non-probabilistic ones are the type of sampling whereby you just target a specific population without actually or you target a certain group of the sample without actually having to have an entire representation of the population. So in a case whereby maybe you have a very rare mental health condition, you might end up using something like a positive sampling, whereby you just target specific people that may be having that condition, or people you have just heard that they have that condition, and or people who are stakeholders in that. And then you do a thorough interview to get information that will compensate the deficiency that will be brought in by your sampling method. So that's all I can say. Thank you so much for the presentation. It's really good. I don't have a background in mental health, but I have some background in statistics. I'm now doing biomathematics, my master's, and I've been doing some bit of research. So thank you so much.
Thank you. That's good. So just to say that although you do mention probabilistic and non-probabilistic methods there, if you're looking at statistical inference, it's usually only valid if you've got a probability that you can put on the person being part of your sample. So I think I'm very cautious about advising people to do non-probabilistic methods for sampling, but I agree that they are in use and they are useful for some of the mixed methods where the quantitative and the qualitative are there. Okay, I'm going to get Caesar to say what he wants to say, and then I'm going to go on to the next slide, which gives you a chance to think. Excuse me. Caesar.
Thank you so much for this presentation. It has been so informative. I'm Caesar from IDI, and I'm a data scientist by profession. I know that most of the algorithms we use behind them is mathematical modeling inclined on statistical means or methods. And I find that some challenges when people use symptoms of a disease to predict it than to use the risk factors. When do you use risk factors to predict a disease and symptoms? And how do you classify it? Is it a prediction of a disease or diagnostic of a disease? Because these are two things that I find around public health and people within the public health circles, which a bit confusing, and I find them a bit vague to me.
Yeah.
Thank you.
Thank you, Caesar. Yes, so I think this is where epidemiology differs from clinical research. I mean, as you say, clinical research is often using symptoms to diagnose disease, and I think that's a very important thing, but that's clinical research. That is not usually epidemiological. Epidemiology is usually about risk factors for disease, and symptoms might be used to define your disease, define your cases, define your what you're looking at in the population, but it won't necessarily be. We wouldn't necessarily consider those as risk factors for the disease, because often symptoms are part of the disease that we're looking at. And so clinical research might be looking at symptoms and signs to define, diagnose our cases, their cases, but epidemiology is much more looking at risk factors. And I think this is where that sort of like research and epidemiological research. Okay. So here's some questions for you based upon sort of epidemiology. How would you define, and feel free to put your hands up, feel free to discuss this. How would you define some of these conditions on the right-hand side? What would you use to define the prevalence of depression in nurses or in any other group, or the incidence of anxiety amongst students in the final year? And these are sort of like different mental health conditions you could have here. Depression, anxiety, psychosis, trauma, etc. And what would then be the denominator, and how would you describe the sampling that you do from that population at risk in order to get your sample? Just think about some of these things. If anyone's got any comments that they want to make, I think that would be quite useful. Otherwise, yeah, I'll wait for a few minutes to get a few comments, and then we can go on to the next part of the lecture. This is 1/3 of what I've got. I'm going to go on to study design in a minute, and then to evaluation of impact. Yeah, so just looking at the questions and answers there. Practical training in sampling. We're not going to. I don't think this course is going to do a practical training in sampling. But there's a lot of good courses on YouTube and on some of the other free courses which you can have a look at. There's also a lot of resources which go through that. I think that the team that we have here for this particular mental health data prize we'll be able to give some advice on it, but I don't think we're going to give a whole course on sampling or how to do sampling, because there's a lot there which is probably not really necessary for everybody in this group. But I think that somewhere along the line, there's a question here about do we need to, are we required to sample if we're using secondary data? I don't think it's necessary. I think you could use all of the data that you get, but there may be something to restrict your analysis to a particular sample, or you choose a sample in which you would actually do that. So quite often not necessary, which is why we're not going into sampling too much of a detail, but it may be necessary in some cases if you're going to collect some primary data. Okay. Okay. Yeah, okay. Right. Any comments then about how you'd measure your prevalence of depression? You know, do you have any tools that you're going to use that would be useful there? I mean, I mentioned in my presentation the PHQ-9 tool, which could be used for measuring depression in a group of people. Yeah, PHQ-9. And, you know, Henry says the BDI as well. Plenty of different ways you could measure that. And of course, you're going to get slightly different results in that, in those cases. Measuring anxiety, again, you might want to say, if you're looking at this over time, you might be wanting to see how many people come into the clinic consistent with anxiety. Of course, you might be able to use the GAD-7 or the EPDS as well. Yes, many different ways of doing that as well. And then in each case, in those first two cases, there's a very clear denominator. What you're looking at is the whole population of nurses in the first case. You're looking at the population of students who are in their final years of university in the second case. And in the third case, you might be looking at patients who are attending hospital and so therefore attending clinic and who have psychosis and they are being treated in that hospital. And then in that second case, you would want to look at the impact of the intervention, how many people have the clinic, have the symptoms, have the symptoms and signs of psychosis are considered to be psychotic at the beginning, and how many of them get better and are no longer psychotic at the end. And that would be the impact of the intervention on the patients that we're seeing. Again, screening the nurses. Let's have a look at the chat here. Screening nursing students, you'd have the denominator, and then you might have a list of all of the nurses, and then you'd be able to apply the screening tool to those nurses during the course of that. Yes. Yeah. So someone's asking where they might get these tools. There's a lot of tools available. I think if you do a search for tools for depression, some of them, just a warning here, some of those tools have been validated for use in Africa. Some of those tools haven't been used in Africa, and so therefore they've not been validated. They've only been used in other continents. And so you have to be a little bit careful about which ones might be useful, because some of the questions might be very context specific. And so you'd need to make sure that you could have that. Right. Okay. What about any difficulties you might expect on this? I mean, the impact of climate change, might be quite difficult, because how are you going to measure that climate change? It's not going to happen over a short period of time. It's going to happen over a long period of time. And you'd need to have some measures which span several years of your, in order to be able to that measurement of the impact of climate change on the prevalence of depression, anxiety, and psychosis. Yeah. Okay. So it's a question frame you're going to be using, whether you're going to be doing this, in a very sort of concise period of time, like the final year at university. It wouldn't take you a long period of time to do that, because you could do that at least within a year, whereas others might take a lot longer to do that. And some of them, they might be quite rare, and so therefore you might not get very many cases there, and you would then have to continue to collect those cases over a longer period of time. Okay, I'm going to move on a bit. We're still going to have some more. You're going to have some more tasks for you to do in a minute. So what I'm going to do now is I'm going to do a little bit of a slight change here, and I'm going to look at study design. So we see that we can measure the different cases, and we can measure the prevalence and the incidence of disease from our different studies. But now, what is the design that we might use in order to be able to do an epidemiological study for mental health, or for anything else, in fact? And we can have some, it's important to have the correct design for the output or for the measurement that you want to look at. And what I'm going to do is sort of have a look at different designs, say that we need to be as accurate as possible in measuring not only the outcome. If we're looking at depression or anxiety or trauma, then we need to measure that as accurately as possible. But we also need to measure exposures. If we're going to be doing an epidemiological study where we're going to be looking at risk factors for a particular outcome, we need to measure our exposures with as good as accurately as possible, that we can have that. And the third point about study design is that we need to measure a lot more exposures, because some of those exposures might be confounders. And I'll just mention this in passing. I'm not going to go into confounders in detail, because we can confounders. The importance of measuring other exposures that might influence that outcome, then that is important, because those other exposures might be confounders, or they might be independent risk factors for our outcome. And both of those are going to be important if we are going to understand what it is influences the outcome that we're looking at. So in an epidemiological study, there is an outcome of interest, which, if it's mental health, it might be depression or anxiety or trauma or something like that, psychosis. But there's also going to be exposures that might be of interest, risk factors, which might be, they might be causes for a particular outcome, or they may be risk factors that are predispose someone to that. So we need to measure all of those as accurately as possible in order to be able to do our epidemiological study. What do we mean by exposures and outcomes? So I've just introduced this term exposure and outcome here. And the definition of both our exposure and our outcome depends a little bit upon the question that we're asking. But the outcome is the event or condition that we want to be looking at in the first place, which might be something which is to do with mental health, but we'll see in a minute, it might be something else that is a consequence of poor mental health. And the exposure that we might want to include in our hypothesis, that is, does stress cause anxiety, or does stress cause depression, or does a marital breakup cause depression? And all of these things will have a primary exposure, and we want to look and see whether that is a cause for the event that we're seeing in our study. However, we might have that exposure and our outcome that we're looking at in our study, but we need to be able to collect a lot of other variables or exposures or covariates or many other ways of talking about these. These might be independent risk factors for the disease, the outcome, and so therefore they might be something which is important to know about in order to assess the factors which are contributing to that disease. But they may also confound the association between our primary exposure and the outcome. And that's something which we need to think about before we even start collecting the data, so that we can have a set of exposures that we are looking at. So here's a question that we might be interested in. We might say we're interested in looking at the relationship between depression and brain cancer. Depression is a mental health condition, but brain cancer is another condition which may or may not. And we might be asking ourselves, what is the outcome here? Are we looking at depression as a cause for brain cancer, or are we looking at brain cancer as something which would lead to depression? And so there are two different ways of looking at this. One is could be have an outcome here as brain cancer, and we're looking at depression as a cause or a risk for developing brain cancer. And the other one, well, let's look at our outcome being depression. Do people with brain cancer have greater levels of depression? And so we can have two different questions, two different studies there, which would be looking at the direction of the causality between these two different conditions. And the other thing to note here is that if we're looking at one question, we might have a set of exposures which are independent risk factors for that particular outcome, and we might have particular potential confounders which are looking at that as well. But if we're looking at the other question, then the set of exposures that we want to look at might be very different, and they might be something that we would have to consider. So depending on which way round the question depends on the exposures that we might want to have a look at. Okay, I can see that a couple of people have raised their hands. Amos and Caesar have still got their hands up. Are you still wanting to ask questions, or are you going to put down your hands, right? Don't get
Yes, I want
confused.
to ask a question.
You want to ask another question? Who's that? Caesar? No.
Sorry.
Yeah.
I want to add you back a bit about confounders.
Yes.
I don't know whether confounders are, you can have a one-size-fits-all approach. Like you could use the same methods in clinical kind of conditions or settings, or you use the same in epidemiological, or you could have different methods in both. For example, maybe just to give a scenario, in which part of the two would you use directly or directed cyclic graphs?
Okay. So directed acyclical graphs, or DAGs, are used in a lot of causal research, a lot of causal analysis, where we're looking at causes which might be leading to a particular outcome. And of course, confounders are very important in that. And those confounders might affect that causal relationship that you're looking at there. I don't think there's ever going to be a one-size-fits-all. There's never going to be saying, well, we have to look at these exposures, and these are the exposures which are important there. I think there's a lot of exposures which can be important at certain times, but not necessarily in all circumstances. So it might be that we'll have to, sort of like consider that. But the important thing at this stage in developing your epidemiological question and being able to answer the to be able to get a good study design is to say you do need to be able to measure lots of exposures, even if some of them may or may not be confounders and some of them may or may not be independent risk factors. You do need to measure them so that you can include them in your analysis, and then you can take into account the way that they might affect your result. So in the chat, what do we say there? Which is the correct design? Okay, well, we'll come on to different designs. I'm not going to tell you one design is better than the other. It depends on a lot of different things there. Abdic says that confounding is mediation variable. Yes, that's one way of looking at it. It changes the effect that you might have between one variable, between the independent variable and the dependent variable, independent variables. Yeah. So the association that we see in in a crude effect or in a univariate or bivariate effect might say that there is an association between these dependent variables, this dependent variable and these independent variables, but confounding might change all of those, and it might show that that is not true after you adjust for other factors. Yeah. Okay, good. So let's have a look. Let's carry on then. Yes, so someone said, what is the correct design? There's a lot of different epidemiological designs and studies here, and some of them on the left-hand side are observational studies, and some of them on the right-hand side here are intervention studies, where we might be allocating our exposure, we might be introducing things to a population in order to be able to assess the effect. If we look on the observational side, we might then have some studies where we are just looking at descriptive analysis, and that descriptive analysis might be data from groups, in which case we would describe those groups and we describe the proportion or the prevalence of mental health conditions in those groups. Of course, once we've described those groups, we may also want to go along to analyze the risk factors for that. And of course, that is going to be, I think it's always important to describe your data to begin with, and then to go on and do some more analytic analysis there. So I would say that distinction between descriptive and analytic is going to be a little bit false. I think we can do both, but we've collected the data that enables us to do both the descriptive and the analytic data. That is not only for our groups, where we might have ecological which compare and describe those groups, but also in terms of individuals, the description of the conditions, the outcomes that we have in our individuals. But we should be able to also go on to do some analytic, some analysis of those and show the risk factors that are affecting the outcome that we have there. So observational studies, we don't do anything in the with the population that we're looking at. We just observe and we record our outcomes. On the other hand, on the other side of this picture, there is the interventions trials, where we might allocate an exposure, we might allocate an intervention, and we say some people receive this intervention and some people don't, or some people receive this treatment and some people receive a different treatment. And those intervention trials are also important in that some of them can be individually randomized, whereby people are individually randomized from the one arm of the trial. And of course, that happens in many cases where there is a treatment or a drug or a vaccine which is available for people. As they say here, data from groups, or we might have community trials or cluster randomized trials where we randomize clusters to receive a particular intervention. And that happens for a number of different reasons as well. And so this is the sort of a brief overview of epidemiological studies, which can be used not just for mental health research, but for many other research studies as well. Okay. Carry on. Yes. So let's have a look at some of these studies in details. Of course, these will collect information from individuals at one point in time. And so what we're really doing here is analyze or describing the prevalence of disease. And we might then have a particular tool, the PHQ-9, for instance, for depression, in which we're going to screen the whole population to find out how many people have that particular disease or condition. And we can then estimate the prevalence of depression within the population by using this tool. So cross-sectional studies are good at that. We define our population, and then we'll sample from that population in order to be able to estimate the prevalence of disease at one point in time there. Of course, it might take us several days or months to do that, but we're still talking about one particular point in time. At that point in time, this proportion of people will have this condition that we're looking at here. And that will be a descriptive study if we're just observing the prevalence of disease and describing the people who have these particular this particular condition. But if we then can collect the current exposures, we can then analyze people and say that those people with the disease have these particular characteristics, and we will then be able to compare them to people without the disease, which will be an analytic study then. And not just the current exposures, by asking the right questions about the history of the factors associated with that condition, we can then find out what might have happened in the past, which would contribute to the outcome that we're looking at here. We might then describe the frequency and the prevalence of our conditions, and we then describe the food associations between our exposures and our outcome. But the analysis of that outcome, we might then do a more analysis where we're going to be adjusting for confounders, and we will then be able to get measures of associations and 95% confidence intervals for our significant factors there. So a cross-sectional study allows us to do not just the descriptive analysis, descriptive of the disease in that population, but also an analysis of both the crude and adjusted associations in that particular. Okay, the next one I wanted to mention here is cohort studies. Again, we might recruit from the population. Our baseline here might be that we have a set of people who are free of the disease. Now, in order to find the people who are free of the disease, we would need to test people on the baseline. We'd need to say, well, who is it that is at risk of getting depression? And we would then screen the people here for that particular condition and say that we're not really interested in the people who already have the disease. What we're looking at here is how disease over a period. And so we're going to follow up over a period of time, and then we're going to have some kind of recording of those people who get the disease. And we might do this in an active way, active follow-up, whereby we'll every month or every so often, and do the same screening and find out how many people have got the who test positive for that particular condition in those repeat visits. We might say, well, we can't afford to do that and do follow-up. We're just going to look at people who come into the clinic. We're going to then say, let's record those ones who present with the signs and symptoms of the disease that we're looking at, or the condition that we're looking at here. And so we'll get a measure of the incidence of the disease over time. The numerator is with the disease, all of the new cases. Even if that case of disease only lasts for a few days or weeks, they will be counted as someone who has had the disease, a bit like the question that was answered earlier about the lifetime prevalence. In fact, we're looking at incidence, and we can accumulate the incidence over time. But the denominator is that everybody who is at risk of the disease, who didn't have the disease at baseline, but who would have been at risk of that disease over the period of time that we had there. The difficult thing about cohort studies is that some people may be censored. And this happens, if you're collecting the data yourself, or if you're looking at secondary data as well. Some people might be censored in that they at risk of the disease for a period of time, but then at a particular time point, they no longer come to the clinic, they have moved away, or they've died, things like that. So if you're looking at the incidence of mental health conditions in people who have HIV and who are attending clinic and receiving their antiretroviral therapy, then you might see that they come to the clinic many, many times, but at a particular time, they might die or they might move away, and they're no longer at risk of having this particular mental health condition because they are no longer attending that clinic. So analysis of cohort studies will use what I call a time to event outcome, and there are lots of different methods for analyzing time to event outcomes, including Poisson regression and Cox regression, and more sophisticated regression methods as well. So cohort studies are very, very useful for looking at incident methods, and we can analyze those. We can, again, I haven't put it on this slide, we can adjust for confounders, we can look at other independent risk factors as well, providing we collect our in our data. Okay. Okay, good. Next one I was going to mention here, case control studies. So case control studies are very different from the two that I've mentioned there, because the starting point for these is a group of people with the disease. And especially if we're looking at a disease which is fairly rare, if we're looking at severe trauma, if we're looking at other rare mental health conditions, maybe psychosis, then we might only see a few people. And if we want to study the prevalence of disease, we'd have to have a very large sample size in order to get just a few cases of this particular mental health condition. So what we might do here with a case control study is start by identifying the cases that come into a hospital, or if we did some community testing, we might identify cases that we have in our community. And we might recruit then as many as we can into our study, so that we can say we have a number of cases there. However, we're not going to then look at the whole of the rest of the population, because there'll be a lot of people there, a lot of information that we would collect, which we don't actually need. But we then identify a suitable number of controls who don't have that condition and who are similar to the ones that we have recruited as cases, and we can recruit them from the population. But it would only be a small fraction of that population that would be recruited into our study, those without the condition, and we would say that the sampling frequency for that, so the controls, would differ from the sampling frequency for the cases. And that's the key thing about case control study, is that the sampling frequency of the case be quite high. We might be getting everybody who is a case into our study, but the sampling frequency for the controls might be quite small. We're only 1 in 100 of our controls into our study from the population. But the important thing is that from both the cases and the controls, we will get a complete history of the exposures, whether they had suffered childhood abuse, whether they had suffered stress, whether they had attended particular courses or universities, or worked in a particular conditions. And of course, those all might be risk factors for becoming a case later in life. However, the issue here is that with case control studies, there may be biases, recall biases, as cases may have a better recall of some of the key events because they've then experienced a particular mental health condition later in life. The other thing about case control studies is that we can't measure the prevalence of disease or the disease in a case control study, because we're not selecting cases and our controls with the same sampling frequency. We the odds and the odds ratios of the condition or the outcome and this is very important, because that enables us to do some very good analytic studies using case control studies, where we're looking at odds ratios for risk factors. And that's, some of the early work with smoking and lung cancer using case control studies, where they identified smoking as a risk factor for lung cancer using those methods. And so I think also with mental health conditions, we might have some very rare mental health conditions that we're going to be looking at, and we could do cases and controls taken from the population or taken from secondary data in order to be able to analyze those data. Okay, the final one that I'm going to be looking at here is the intervention studies, which includes randomized controlled studies or trials. And often here we're starting with a baseline cross-sectional study of the population at risk, all of those who are going to be eligible for the interventional trial, whether it's geographically based or whether it's based in a hospital or whether it's based in a school or workplace or something like that. So the objective here is to identify those who are eligible and those who are free of the disease, so that we can then look at that. It might be that we're looking at those who are free of the disease and we're looking at incidence of disease. It might be that we're looking at people who are have the disease, and we're going to have treatment or an intervention which is going to be given to those people with the disease, in which case we are going to have people who have the disease as our eligible. The key thing about randomized controlled trials and cluster randomized trials is that there is a randomization, that individuals don't know whether they're going to receive the intervention or not. There is a way, an allocation of that, which is completely at chance. It's not my responsibility. It's not the choice of anybody in the study to give that person the intervention or not. That is determined by chance through a spin of a coin, through the numbers in a pre-sequence that we have. And those people then, some of them receive the intervention and some of them are not. And the reason for the randomization is that then we have two groups of people who are utterly comparable. You have the same proportion of people who are males and the same proportion who are females, the same proportion who are old, the same proportion who are young, and the same proportion in both groups for all of those other characteristics. When we then follow them up over time, the objective then is to measure the outcome after a period of time and say, if there's a difference in the outcome between the group who received the intervention and the group who didn't receive the intervention, then that difference is due to the effect of the intervention that we gave them. There is a question here about what about follow-up, and there's a big question that rises every time a trial is conducted, is that if there's a lot of people who are lost to follow-up, we could be missing out and we could be biasing our responses by that. However, intervention studies, randomized controls, gold standard assessment. They are the ones which are used by governments, and regulatory authorities, and clinical companies, pharmaceutical companies, to say this drug, this vaccine intervention is good for this particular disease. So they are the gold standard for the effect modification, for the effect assessment, but they may not be fully representative of the whole population, because often randomized controlled trials, they say the eligible people have a particular set of characteristics, and anybody who doesn't have those characteristics may not be part of that trial. And we don't really know what happens in those who are not chosen for the trial. So there is some questions there about intervention trials, randomized controlled trials, as to whether they're representative of the whole population. Okay, I'm going to have a look and see whether there's any more questions here. But in the meantime, I'm going to ask you, study designs would you use? You remember those five research questions or questions that you had in task one? What study designs would you use to study these outcomes? I'm just going to have a look at the chat and the questions. Okay, most of the questions are for Diana to get something from the sites. Yeah. So, someone's asked an interesting question about snowball. Now, snowball sampling is often used in qualitative research. So snowball sampling is something which whereby one person is asked some questions and given some responses, and then they're asked to refer other people into to be asked the same questions. And that's very useful for qualitative research. I'm not a qualitative researcher, and epidemiological designs are much more based upon randomization and chance. And so snowball sampling is not something which we would use in an epidemiological study. Okay. Yes. So someone's then asked me for a case control study, an example of a case control study for the risk factors for lung cancer in a population next to a paint factory, for instance. Lung cancer, and other conditions are quite rare. And so what we would do is we'd set up a cancer tree in the hospitals so that we could detect anyone who comes into the hospital. And of course, people might come into the hospital and be identified with lung cancer, and we get cases of lung cancer, and we would have lots of people there. And some people might not still live next to the paint factory, but they may have done in the past. And so we'd ask them a set of questions about, where they lived, whether they worked in this paint factory, whether they lived close by, whether they drank water from the wells which were close by to this paint factory, etc., etc. And of course, all of those questions would be very useful. But unless we have our controls, we wouldn't know whether those were risk factors for the lung cancer or whether they were just things which happen to everybody in that particular area. And so we recruit our controls from people who don't have lung cancer, and we could recruit them from people who are attending other services in the hospital. We could, so the one thing is we could have controls which are selected based upon their attendance in the same hospitals, and that would be one form of controls. We might also choose controls who are living next door to our lung cancer patients, and so therefore we would be able to say, yes, we could choose them. They're going to be very similar to the cancer patients in where they lived, and we would then ask them whether they came from the hospital or from the workplace or from the residents, close by residents. We could ask them the same set of questions that we'd ask for the lung cancer patients. Have they lived in this area? Did they work in that paint factory? Did they get any services like water from the wells? Which are the difference between the responses from the cases and the responses from the controls would give us an odds ratio for the factors in terms of their association with the lung cancer that we are observing. So that's an example I give. I don't know whether that's useful to you, but let's have a look at what is here. Cross-sectional studies, prevalence of depression. Yes, cross-sectional studies will be able to give us an idea of the prevalence of depression. And because they are all located in one point in time, that would be quite useful. Cohort studies measure incidence. Yes. Okay. Who's this? Someone wants to unmute. Okay. Okay, I think I've got most of those there. Ecological studies. Ecological studies is where we have data from groups, but we don't have data from the individuals within the groups. And we might have that data if you're looking at the HMIS data from hospitals and from health facilities. We might have each of our hospitals. We can't tell anything about the individuals there, but we might be able to say that in this hospital there were 25 cases of depression who were in the last month. In this health center, 5 cases were treated in the last month, and we can relate the numbers there to the services which are available in those health facilities. So an ecological study might be able to tell us something about the facilities which are serving those particular people. Okay, anyone have any other questions there? Case control study for the depression, cohort study for the incidence of anxiety. Yeah, ecological impact on climate change is good. Yeah. Okay. I'm going to, unless there's any other questions I can see here. Oh, is there a couple of attendees who've got their hands up? Let's have a look. Yes. Who's this? Dr. Yinka, do you want to allow you to talk? And do you want to ask your question? And Faith, I'll allow you to talk as well.
Good afternoon.
Good afternoon, yes.
Okay, you can hear me. Thank you.
Yes.
Thank you, Jim. Thank you for this lecture. Very enlightening. I just want to understand the relevance of effect size, and
Effect size, yeah.
and randomized control or intervention study. And that is number one. Number two, I want to know the difference between odds and odds ratio.
Okay, good. Okay, so thank you very much. Good question. So effect size is really, I mean, before you start a study, you should be able to say, what is the size of the effect that I want to look at? You know, are you looking at a big effect or a small effect? And of course, it would be important, biologically important, clinically important to look at an odds ratio of 2, let's say twice as many people, or odds of being treated successfully with a particular drug is twice as big in one group as it is in the other group. And so, you know, we're looking at effects usually, and in an intervention trial, then we're usually looking at quite big effects. Does this vaccine prevent 50% of the cases of meningitis or 50% of the cases of COVID-19 or whatever it is? Does, you know, we're looking at big effect sizes. And the big effect sizes really determine the sample size of our intervention. And so the intervention is powered to detect a particular effect size. So the effect size is going to be important in designing, in calculating our sample size. Sorry, some people are asking for a body break as well. Maybe after this, we can just have a 5-minute break. Right. The thing you asked, Yinka, was about odds and odds ratios. Now, if you've got one group and you're looking at the odds, if I go back to, yes, okay. In fact, I think it's in the next part of one group, and you're looking at odds of depression in the males is going to be the number with depression divided by the number without depression. And so that's going to give us the odds in one group. If we're going to compare two groups, then we're going to look at the odds ratio. The odds in one group divided by the odds in another group. And so that's going to give us an odds ratio. Okay, so odds ratio is about comparison of two groups. Odds is the thing that you would calculate in one group only. Okay, so I think we're going to have a short break here of 5 minutes. I'm aware that I've got a couple of hands up here. I've got Faith, I've got Abdi Karim, and I've got Odette. So when we come back, is that okay if you ask your questions after we have a short break, or should I have a short break? Should we have a short break now? Is that okay? Okay, I'm going to just mute and stop the video for 4 minutes. Is that okay? Talk. Dr. Abdi Karim as well, if you're there.
Hello. Hello.
Yes, hello.
Can you hear me?
Yes.
Still, I have a problem for the effective size. I am not get your point. You are divided into two parts: big size and small size. You says if the sample is greater than 50%, it is big size. Mostly, it is calculating for the sample size, but for the small size and big size, still I need to for the clarification.
Yes. Okay. So say you're looking at depression, and you say the prevalence of depression in one group of people is 5%. Oh no, let's say 5. Yeah, it's 5%. That's good. If it's 5%. Now you want to compare the group of people who have a prevalence of 5% with another group of people who have a prevalence of 10%. So that's twice, the prevalence is twice as much in one group as it is in the other group. And of course, if you do that, you can calculate your sample size, and you might come up with a sample size of needing, let's say, 200 or 300 people in each of your groups, in order to be able to calculate, or in order to be able to show that result as significant. And that's quite a large effect. Twice as many people have depression in one group as they have in the other group. If you say, they have 5% in one group, I want to find out about people who have 6%. I want to look at an effect size which is very small, which is only a 1% difference. Instead of needing 200 or 300 people in each group, if you're looking at a big sample size of 5% against 10%, to look at the difference between 5% and 6%, you're going to need thousands of people in each group. You maybe need 3,000 or 4,000 people in each group, simply because looking at a very small sample size, a very small effect, means you need a large sample size. And of course, the difference between 5% and 6% might be, you might think it's important, but actually clinically it's less important. That difference between 5 and 10% might be quite clinically important. Between 5 and 6% might be saying, oh, there's not a lot we can do there. We can't put all of these resources in reducing our prevalence of depression or treating people with depression with such a small effect there. And so having a large sample size is a problem. It takes a lot more resources, and you're going to be trying to find a very small effect size, which is not necessarily clinically important. Having a smaller sample size, but looking at a bigger effect is going to be more important in the long run. Okay. Thank you for the question, Dr. Abdi. Okay. Odetta, let's have a look and see if I can allow Odette to ask a question.
Okay, thank you. Can you hear me?
Yes.
Okay, so my question is with respect to the effect size. So I was doing an intervention study on post-traumatic stress disorder. So I couldn't find, like in literature, an effect size that has worked based on my interventions. So it was really kind of tricky to get the effect size so as to calculate the sample size for the intervention study.
Yes, that's often the case, and often you can't find there's no published literature which says this is the effect size you should be looking at. But of course, an effect size is something that you're going to, as the PI of the study, you're going to say, I think that this is important. Something that you will define as important for your study, and say that if you had this big, an effect size this big, then this would be important to you, be important to the research community to show that this particular intervention will help with post-traumatic stress in this particular condition or something like that. And so you're determining what that effect size might be, but that effect size will then affect or will determine the sample size that you have for your study. Okay. Okay. So Reagan has got a list of questions here. Okay, that's mostly the answers to the questions I had there. Yes. Okay. Yeah. Yes. So you can look these up in some of the books. They will have some plausible ranges for sample size for effect sizes that might be looking at, and they will then lead to particular sample sizes that you want to have there. Thank you for that. Was that Ronald? Was it? Yeah. Okay. I'm going to carry on then with the next bit of this, unless there's anybody else there. Oh, Asrat. Final question before we move on.
Yes, please. Can you hear me?
Yes.
So my question will be on research designs. Like there are two types of designs: descriptive and quantitative and qualitative. So if a study, for example, is studying the prevalence of a disease and the associated factors for that disorder, is this going to be a quantitative or a qualitative study, or is it a mixed one?
I think if you're going to look at the prevalence, then you're going to be collecting measurements of particular things, and so therefore it would be quantitative. I think the quantitative aspect means you're collecting numbers, you're determining what the scores are, what the exposures are through a quantitative number system, whereas qualitative is much more about asking questions, looking at reasons, finding out what people say is how they're feeling and what their causes might be in a descriptive way which uses words rather than numbers. That's how I see it. Qualitative is often about looking for reasons using words, whereas quantitative is often about collecting numbers. Of course, the numbers represent yes and no. The numbers represent the different categories that you might have in your exposures, but it's a quantitative way rather than a qualitative way. So, and there are mixed methods which use both, but I think in some ways they are a combination of both qualitative and the quantitative methods that we have together.
So we should say it's a mixed one.
Sorry?
When we use it. So if we study the prevalence and the associated factors, we should say this is a mixed study.
I would say it's if you're going to look at prevalence of a condition and risk factors for that condition, then it's likely to be a quantitative, statistical methods rather than qualitative methods. Which so I would say those are quantitative methods. I think there's a lot of talk about the difference between the two, but they're both trying to understand what it is causing a particular disease, particular condition. Yeah.
Thank
you. Okay, good. Okay, so let's move on then and have a look at. So this is about evaluating the effects or the impacts, and I know that there's been a couple of questions about this in some places. How do you look at the odds ratios, or what's the difference between odds and odds ratios, and hopefully I can try to explain that in the next few slides. So measures of effect. So really this is about comparing two groups. What I've said so far is about measuring the effect in one group, and then we looked at study designs as to what we might be able to, what designs we should be using to be able to calculate those measures. And now I'm going to go on to say, well, if we're going to compare different groups, if we're going to compare an exposed group to an unexposed group, then we're going to get a measure of effect. And this links up with what you've been talking about for odds ratios and other things like that. And we can use measures of effect to describe the differences between the frequency of disease in the exposed population groups. So we could have two groups here, and we could look at them at the end of a particular time and say, in group 1, we have a prevalence here, which is going to be D1 over N1. And in group 2, we'll have a prevalence which is D2 over N2. And we might be able to say, well, in one, it's a prevalence of 8%, and in the other, it's a prevalence of 12%. And that's quite nice to describe those differences in different groups. However, what we want to do with our analysis is perhaps go on a bit further than that and say, can we describe the differences? And here we might describe the risk differences. We might describe the rate differences if we're looking at incidence rates. And the incidence rate differences will be the rate in one group minus the rate in the other group. But differences are often used to describe the differences between different groups, but we don't usually use them in analysis. Often we're going to use ratios in our analysis. We're going to say the risk ratio is the number who are positive out of the total population in one group, and the number who are positive in the second group divided by the total number in that population. And that's a risk ratio. We're dividing the risk in one group with the risk in the second group. A rate ratio, again, is going to be the rate in one group where you have the number positive divided by the total time at risk. And then this is going to be divided by the number positive in the second group divided by the total time at risk in the second group. The odds ratio here is going to be the odds in one group divided by the odds in the second group, and those are going to be used for some analysis there. And so often when we come to doing the analysis, we're going to use risk ratios, rate ratios, and odds ratios far more often than we use risk differences and rate differences, simply because the statistical methods that we have for using ratios is more advanced and more comprehensive. However, what we have here is we have these measures of effect, which are differences in ratios. But what we need also is to say we need to have another aspect when we come to comparing our estimates. When we compare our estimates, we need to have a hypothesis test. We need to say, what is the null hypothesis for our estimate, for our difference? And the null hypothesis is usually that there's no difference between the estimates. Oh, sorry, there's a typo there. And we need to say, well, how do we know whether 8% and 10% are different? And is 12% and 15% different? How do we compare those and show whether they are statistically different, statistically significant? And for doing this, we need again to have the standard error of the difference. And again, this is the standard error that we had for our estimates and for our incidence estimates. We can obtain these standard errors from our software packages. And these standard errors will tell us about the variability of that estimate we get. The estimate we get is from our sample, but of course, if we did the same sample again, or a different sample from the population, we would get a different estimate from that. And standard errors of our differences depend upon the outcome that we're looking at. If we have a continuous outcome, if we're looking at the score, let's say the mental health might be getting from a particular tool, then we might say, well, we're going to compare the mean in one group with the mean in group to see whether they have different mental health scores. And the difference is the difference between the two. And the test statistic is going to be the difference divided by the standard error of the difference. And the standard error of the difference depends upon the normal distribution here is going to be S squared, the variance divided by N for the first group, and S squared divided by N2 for the second group. In other words, the variance in one group divided by N, and the variance in the second group divided by the number in that group. And that's going to give us the standard error of the difference, so that we can use this in the comparison and to see whether or not that difference that we observed is significant or whether it's small. For proportions, again, the difference is going to be the proportion in one group minus the proportion in the second group, but the standard error is going to be different because it's based upon a different distribution. And in this case, it's the binomial distribution. And so we have P1 multiplied by 1 minus P1 over N1 plus P2 times 1 minus P2 divided by N2 in the second group. We add those two variances together, and then we take the square root of that to get the standard deviation of our difference, a standard error of our difference, sorry. And we can use the standard errors to compare the differences that we observe and see whether or not they are significant. Standard errors are also important to give us something like standard 95% confidence intervals, and every measure that we take, whether it's impact measures, whether it's odds ratios or risk ratios or whatever, we need to have that. And the estimates from the methods, as I said in the previous slide, which are used for the analysis, are obtained from the distribution that we take them from. Standard errors of the difference are used to create 95% confidence intervals for those differences. And we can see this is what has been presented in a paper here, where we have standard errors around the differences for different groups within this thing here. We can see that the standard errors present a range of values which might be useful. And these are the range of values that we expect to see in the whole population. And they're a good visual way of seeing differences there. We can identify the big differences that we have here when we have an unadjusted analysis. And some of those differences disappear when we have an adjusted analysis. But we can see here, down here, there's religious attendance here might have a significant effect on the mental health of particular people in this sample. Okay, so just as we have our measures of effect for differences, the odds ratios and the risk ratios will also show, will also have standard errors associated with them, and they're calculated on a log scale because they are ratios, odds ratios and risk ratios are calculated as differences on the log scale, and these then are back translated as multiplicative increase and decrease from the point estimate. And so we can see here that what happens is that people then represent the differences by age group here for postnatal depression. This is from a paper that here, and we're taking our 30 to 34-year-olds as our baseline, and we can see that for each of our other groups, we'll get an unadjusted rate ratio here of 1.23 with a confidence interval goes with that. And we can see that the confidence intervals, if they include a rate ratio of 1, then they're not going to be significant. So incidence rates, odds ratios, and risk ratios all will use a standard error which is calculated on the log scale and use multiplicative 95% confidence intervals. Yeah, so that's what we've got there. When do we use our different measures of effect? Well, if we have a cross-sectional study, we will get perhaps the odds ratios and the prevalence ratios from that particular study. We will be able to use those in our estimation of size of the effect sizes that we see, and we will be able to get a test of that against the null hypothesis of the odds ratio or the prevalence ratio is equal to 1. In a case control study, we will only get the odds ratio. We won't be able to get the prevalence ratio because the case control study does not estimate the prevalence, because the cases and the controls have been chosen with a different frequency. The cohort study, we will usually get the rate ratio. The reason why the risk ratio is here is that some people call the rate ratio the risk ratio. I think the risk ratio is a little bit ambiguous in what it means. I think that risk ratio is often used as a term for any type of ratio that we have. But rate ratio is proper cohort study where we're comparing the rates in one group with the rates in the second group. Okay. So how are these measures related? Well, if the disease is rare and we have appropriately designed studies, then the odds ratios and the risk ratio are going to be approximately similar. The odds ratio and the rate ratio are most often used in epidemiology because that is the mathematical means by which we have, which have been programmed into our statistical calculations. the logistic regression and the Poisson regression that we have for rate ratios are going to be the most useful and easy to use in epidemiological studies. Okay, so I think effect measures are going to be something which we will use when we compare different groups, and we can do that whether we're using primary data that we've collected ourselves or whether we're using secondary data that we've obtained from elsewhere. Just as a quick task number 3 before I finish, this is a 2x2 table. Can we calculate the risk difference from this? Can we calculate the risk ratio and the odds ratio from this? Yes, we can. The statistical test shows that the chi-squared for this particular 2x2 table has a value of 29 and a p-value less than 0.001. How would you interpret this finding? And then the second question here, if you wanted to develop a study to explore the effect of doubt on anxiety, what population would you use for this study? And what study design would you use? And how would you measure the anxiety that might be present in this population? So that's how I'm going to finish. Any questions we can ask for some questions, or any hands up, I can have a look and see whether we can get some comments from different people. Just looking at the comments in the chat. Most of them are about the attendance log and the link to that. So I'm not going to answer those. I'll let Diana answer those.
Hello, Doctor.
Any comments on this?
Hello?
On this question? Calculate
Can
the
you
risk
hear me?
difference, the risk ratio. Yes, who's that?
Abdul Karim.
Dr. Abdul Karim. Yes, that's right. Go ahead.
You are highlighted for the last session in this presentation.
Sorry?
If,
Yeah.
you are highlighted in this session, especially for the last session, if the disease it is rare, mostly probably the odds ratio and risk ratio and rate ratio are the similar.
Yes. Yes.
How
They're
it's
not
possible?
they're not going to be exactly the same, but they could be similar. Yes. Go ahead.
What I mean, there is a evidence-based studies available for this issue. If yes,
Well,
you can share.
yes. Go ahead. Go ahead. Yes.
If yes, we need to share this information. This is new
Yes.
for me. I need to learn more about. If the disease is rare, mostly you says it's a similar odds ratio, risk ratio, and rate ratio. It is mostly
Yeah.
probably a similar.
Yeah. So if the odds ratio is, if the disease is rare, that means, let's say the prevalence is less than 1%, in which case, it's going to be the prevalence ratio, the prevalence in each of our groups is going to be divided by the total number at risk. Okay, and if it's less than 1%, those are going to be, 1% in each case, let's say, or something like that. Where if we're calculating the odds ratio, we're going to be dividing by the number who haven't got the disease. And although that's not going to be exactly the same as the number who in total, it's going to be very similar to that. It's going to be dividing by 99 rather than 100. And so the estimates of our odds and our odds ratios are going to be very similar to the to the estimates of our prevalence and our prevalence ratios. So that's just due to the fact that we're looking at something which is very rare, less than 1%. And similarly with the rate ratios, they are also going to be very similar to the prevalence ratios and the odds ratios. Yes. So I'd have to look it up in a book and get you the evidence, but I'm sure it's in something like Heineken's or something like Woodward and co. But the evidence is there for the rare diseases, the odds ratio, the risk ratio, and the rate ratio all going to be similar. Okay, Dr. Yinka first, and then we'll have Riri.
Can I ask another question?
Okay, yes, Abdi Karim, yes. Hang on 1 minute.
For the standard error, you are telling us they are using mostly for the testing hypothesis and creating confidence interval.
Yes.
During the development confidence interval, mostly we use 95%, 99%, and 90%. Why we use 95%? In our setup, mostly we encourage as we are medical, it is better to use 99% rather than 95%. Any update for that, for the difference confidence interval for 90%, 95? Why we use 5 rather than 91%?
Yes, so 95% confidence intervals and the 5% significance was, I think, is something of a legacy from the Fisher, who first developed these tests back about 100 years ago. And he thought this was a very convenient sort of like number because it was close to 2. And so he said that a confidence interval where you multiplied the standard error by 2 would give you something which is quite intuitively interesting. And 5% he thought was sufficiently small to be useful for most people. They say, yes, we can sort of take a 5% significance. Anything less than 5% is going to be significant. And that. So there's no real reason for it. It's just something which has grown up over time as something convenient. Which I think in epidemiological studies is quite useful. Having a 5% significance and 95% confidence interval seems to fit well with epidemiological studies. Janet and many other people who want to have a much stricter confidence interval will often take 99.9% intervals because they really do want to be sure that they are restricting, they are looking at something which they can be 99.9% sure that the effect is within that range. And so I think there are groups of people who have taken other confidence intervals and other significance tests, which are different from what we use as epidemiologists. But I think in epidemiological studies, I think the 5% significance and the 95% confidence interval is still the one which is most used by people today. And I'm very happy for other people to use other confidence intervals and significance tests, but I think it's going to be difficult to change epidemiology as it is now, where we use 5% significance and 95% confidence. Okay. Thank you for the question, though.
Thank you,
okay. Dr. Yinka, you had a question.
Thank you very much, Jim. My question is, how can one calculate odds ratio for cross-sectional study, knowing fully well that it's just one group? Cross-sectional study is just across a sample size, one group. Is a snapshot.
So we have a 2x2 table right here on the screen at the moment, in which we have 25 have experienced anxiety and have, had a background of drugs. And so this might be a cross-sectional study because we measure the anxiety in these 500 people, and we find that 50 people had anxiety, so 10% anxiety in this population. And we also asked them a question about, did you experience gout in the last year? And of those, 100 or 20% had experienced, got that wrong with that. 100 people had experienced anxiety, isn't it? Which is 20%. and 50 people had experienced drought in the last year. So we were looking in one particular district, perhaps, and for 50 people, they had experienced drought, and perhaps they had crop failure, and perhaps that added to their anxiety. So 100 people had experienced anxiety, and 50 people had experienced drought here. So it's sorry. So 50 people here and 100 people here. So we can estimate the odds of anxiety amongst people who experience drought, and the odds of anxiety amongst people who experience drought. That was taking this column here, and here we have 25 people here who have experienced anxiety and drought, and 25 people who have not. So the odds there is going to be 25 divided by 25, which is 1. Okay. And so we'd say that the odds of anxiety amongst this group here is going to be 1. The odds of people who experience anxiety amongst those who didn't experience drought is going to be 75 divided by 375, which I'd have to do the calculations. 75 divided by 375 is going to give about 0.2. Okay, so the odds in this group here who have experienced drought is 1. The odds in those who've not experienced drought is 0.2. So the odds ratio is going to be the odds in those who are exposed, experienced drought, divided by the odds of those who are not exposed. 1 divided by 0.2 will give us an odds ratio of 5. So we just divide the odds of those who are exposed divided by the odds of those who are not exposed. Does that answer your question, Dr. Yinka?
Yes, it does. But I'm just looking at this table that maybe it's a case control study.
It could be a case control study. It could be a cross-sectional study, and the output in the table will be similar for both.
Okay. Thank you very much.
Okay. Okay. Question from Riri. Do you ask your question?
Yes, Professor, thanks so much for taking us through this session. It has been very informative. However, I have one thing that I just wanted to clarify. Any session of this nature is an opportunity to always learn new things. So we had a section on calculating sample size. I would like just to get some clarification on calculating a situation where we can have 2 population proportion formula. In which situation can we be able to use 2 population proportion formula?
Mm-hmm. So you want the formula for sample size, is that right?
Yes. Formula for, yeah, I just wanted to find out in which situation or in which condition can one be able to use 2 population proportion formula.
Okay, so if you're comparing 2 populations or 2 groups within a population, then you should be able to use that 2 population formula. Yes, and of course, the sample size you can use, you've got different sample size calculations if you're going to be using an outcome which is a continuous outcome, such as a mental health score, or if we're using a proportion or prevalence, then you have a different sample size calculator. And if you're using a rate, then you'd also have a different calculator. But each of them, use a very similar kind of 2 population calculation. And you can use that if you have 2 populations within the same two populations which you're comparing, which are different from each other, or 2 populations or 2 groups within the same population.
Okay. Okay, thank you.
Okay, good.
Thank
you. Okay, James, I'm going to give you a chance to unmute and talk and ask your question. James and Dimby. Okay, James, you've got a question.
Yeah, sorry,
Yeah. Oh, sorry. Was that a mistake then? Yes. Okay. No problem. No problem. Okay. It says, how did you get the chi-squared value of 29? I'm getting a value of 31. Okay. So in this 2x2 table that we've got here, I had a chi-squared of 29, but our team gets 31.25, which is fine. I think the difficulty, I mean, the thing is there are slightly different ways of calculating chi-squareds. And a value of 29 is very large. A value of 31.25 is also very large. I think the point is we shouldn't get too worried about whether we get small differences in our values there. Both of these are going to be highly significant because the value of 29 on a chi-squared from a chi-squared distribution with 1 degree of freedom is going to be very, very small. It's going to be less than 0.05. So we're going to have a significant test here. We're going to have a significant difference in the anxiety between those who experienced drought to those who didn't experience drought, because the chi-squared value here is way bigger than you would expect from the 5% significance on 1 degree. And so we should interpret this finding as saying we can reject the null hypothesis that anxiety is the same in people who experience drought and people who don't experience drought. And we can say that, yes, there is greater anxiety amongst people who experience drought than people who don't experience drought. And if we calculate the odds ratio as we did there, the odds ratio would be 5. For people who have experienced drought, they would have a 5 times higher odds ratio or odds of anxiety than people who didn't experience drought. Okay. If you wanted to develop a study to explore this effect, then you would have to use the population of the district, which is to drought, at least subject to drought, and some of it is not. And you would then be able to do a cross-sectional study on this, but you could also use a case control study, as someone mentioned earlier in the conversations. This could come from a case control study as well, whereby we're looking at people who come into the hospital with signs and symptoms of anxiety, and we ask them some questions about whether or not they've experienced drought in the past year or 2 years. Yeah. How would you measure the anxiety? Well, we could use a screening tool for that, or we could use a more precise clinical estimation of the effects of to measure anxiety. I'm not a clinician, so I wouldn't be able to say exactly what that clinical examination would be, but I'm sure that there are some people here who could provide that. Okay. Any final questions here? As Joel says, materials on this course will be provided using the website that you have there, the Mental Health Data Prize Africa .aphrc.org, and then we can also, there's also on YouTube. Dr. Inka says, when should one use less than 0.001? I think if you're a geneticist, I've got a need for a very strict significance test of 0.001, then you can do that. I think most epidemiologists would say, even if they get a p-value there of less than 0.001, they would say that's significant because it's less than the 5% that we usually use for our significance test. Okay. So I'm not saying that we have to use 0.001. We should we should accept the fact that this is going to be significantly different. Anxiety is significantly different between those who experience drought and those who haven't. Odds ratios have a range. An odds ratio is got to be positive because it's got to be greater. The odds ratio of 1 is the null hypothesis. Odds ratios of less than 1 represent some kind of smaller odds of the outcome in the exposed compared to the unexposed. Odds ratios greater than 1 represent larger odds of the outcome in those who are exposed compared to those who are unexposed. All of the odds ratios are positive. You can't have a negative odds ratio. Odds ratios which are close to infinity or close to 0 are almost complete in terms of the association between the exposure and the outcome. An odds ratio of 20 makes sense. It just means that there's 20 times higher odds in the exposed group compared to the unexposed group, which means that it's a very high effect size, very large effect size, and you wouldn't need a large study size to ascertain that odds ratio. Yeah. I think we've reached the conclusion. It's about 4:30 my time, probably different times in different parts of Africa. Say thank you very much for attending. If there's any questions or further comments, I'm happy to answer them through the team in the Mental Health Data Prize, which I shall be part of, which I am part of, and look forward to further discussions and things as we go on. Any final questions there? Any final hands up? Otherwise, I shall say thank you very much. And we shall. When's the next one? Joel, Diana, when's the next training session?
The next training session should be on the 23rd, but we shall share the invitation valid on our link. Yeah, once everything.
So that's next Friday, is it? Yeah.
Yes, that's next Friday.
Okay.
Yeah.
Thank you very much.
Okay, thank you. Thank you so much, Professor. It was quite an interactive session. I'm sure so many people have learned a lot and they're very glad. I can see through the reaction. Yeah.
Yeah. And thank you. Thank you for all the comments, because I really do like to hear what people have got there and how their reactions to it. Thank you. Okay, thank you very much.
Thank you for the wonderful presentation. Thank you, Allah.
Okay.